Sometimes if those arrows will denote, people can present with an epidural abscess. That can occur with people who are in sepsis, they are febrile. So you can think of a paraspinal abscess or an epidural abscess also, which I have seen in practice. Well, it hits you on your face, tuberculosis of the spine. Tuberculosis of the spine is definitely seen commonly. Very important. The classical presentation is severe low back pain associated with fever, night sweats, and loss of weight and loss of appetite. Initially, the X-rays may not be able to pick up. The CT may pick up. The earliest thing which will pick up is an MRI, which shows completely destruction of the vertebra. That's very important. So we finished low back pain due to mechanical causes. Non-mechanical causes is mainly malignancy, immunoinflammatory mainly spondyloarthritis, then you have Paget's disease, and then it is related to infection, and now we have due to visceral disease. All of us should remember one thing. There is something called referred pain. A person with prostatitis can also present with low back pain. Women, every lady who comes to you with low back pain, please have a gynecological opinion to exclude gynecological diseases like endometriosis, chronic pelvic inflammatory disease. If the person presents with low back pain, something suggestive of a renal colic, you'll have to think of renal stones. Here is a patient who's very febrile, looks septic, has got severe pain, low back pain associated with loin pain, with tenderness in the renal area, urine is loaded with pus cells, ultrasound shows pyelonephritis. So think of pyelonephritis also, very rarely perinephric abscess. Among all this, the commonest cause of low back pain in a woman will be chronic pelvic inflammatory disease and endometriosis. In men, especially beyond the age of 60, we have to exclude the possibility of prostatitis in any age group. If it is suggestive of renal colic, you think of nephrolithiasis and acute pyelonephritis if he gives a history of recurrent urinary tract infection. So this is a classical picture which shows prostatitis in a patient. See, that is a typical prostate, which is the granulomatous prostatitis, which can be secondary to tuberculosis. So this is prostatitis. Initially, you detect it with an ultrasound. The ideal one would be to get an MRI. Now, endometriosis, you see that arrow indicates the cysts on the ovaries. So endometriosis is a condition where women present with painful periods. Dysmenorrhea is very common in women when they have endometriosis. Now, endometriosis is treatable. It is one of the most important causes of infertility. So if any lady comes to you with low back pain and infertility, you will have to think of the possibility of endometriosis. You can get an ultrasound done, or you get a CT done, or you can get an MRI done, depending upon this, what we call the site of the lesion as well as the stage of the lesion. Patients presenting with low back pain, lower pelvic pain, painful periods, think of chronic pelvic inflammatory disease. This is important, which we can't afford to miss at any point of time. The ultrasound may be able to pick it up, or you get a CT, and this MRI shows chronic pelvic inflammatory disease on the left side. Sorry. Now, if you see at the right side of the CT, you see multiple stones in the renal parenchyma, so and in the outflow tract. So this patient presented with a low back pain associated with renal colic, picked up by CT. He had renal stones for which he went in for lithotripsy. Well, if they do not settle, ultimately you will have to do an open surgery. That's important. Person presenting with fever, pain in the renal angle, in the loin with renal angle tenderness on a background of sepsis, you'll have to think of perinephric abscess, which can be seen with a classical CT scan. Now there are other visceral causes. I still remember When I joined Apollo Hospital about 27 years ago, one of the first patients I saw was a patient who had presented with low back pain and renal failure. So when I went into the history to find out the cause for the renal failure, he had taken only just 4 tablets of ibuprofen, subsequent to which he went in for an acute renal failure. Now, because it is a renal pathology, we just did an ultrasound of the abdomen, especially kidney, ureter, bladder area, and he was found to have a very large kidney hydronephrosis, which was secondary to retroperitoneal fibrosis. So basically what happened, it was a low back pain, renal in origin due to hydronephrosis. So every person with low back pain, if you think it is not spinal in origin, it is essential that you get an ultrasound of the abdomen, complete abdomen, including the kidney, ureter, bladder, as well as the pelvis and the pelvis, as well as the pelvis for both prostate and gynecological pathology. Sometimes pancreatitis can present as low back pain. A penetrating gastric or duodenal ulcer can present. One of the commonest causes of pain in the epigastric area and lower down penetrating to the back is pancreatitis. So how do we make a diagnosis? You see, this is a remarkable picture. You know, an elderly lady, probably about 65, presented to me with severe low back pain. Pain was there night, day in and day out. X-rays were normal. We did an ultrasound. That showed a mild, what you call an aneurysm of the abdominal aorta. And you see that aneurysm is actually causing erosion of the vertebral body. If you see here, it is actually causing erosion of the vertebral body. Doesn't mean that everybody who's got low back pain, you will have to think of aneurysm of the aorta causing erosion of the vertebral body. But these possibilities can also occur when you find all the investigations are not struck gold. And so this is a CT of a person with pancreatitis who also presented with low back pain. So we finished the common causes of low back pain. It is mechanical, it is non-mechanical, it can be malignancy, it can be secondary autoinflammatory like spondyloarthritis, it can be metabolic like Paget's disease, and then we came down to visceral disease, especially most important is pelvic diseases and endometriosis in women, prostatitis in men. That's a very important cause. Another important cause is pancreatitis. Do not forget the commonest causes of low back pain a little beyond the disc. Well, it can be infection, especially it can be tuberculosis, it can be spondylodiscitis. Very important, low back pain, it can be due to ankylosing spondylitis. You'll have to take a history. That's very, very absolutely essential. And last but not the least, you can also think of Paget's disease. Never forget osteoporosis with or without fracture when an elderly person comes to you with low back pain. And never, never, never forget the possibility of neoplasia. Always keep it at the back of your mind. Now, how do we classify low back pain? It can be acute if it is less than 4 weeks. It is subacute, it is between 4 to 12 weeks. And it is chronic, it is more than 3 months. So the subacute and the chronic only are big problems for all of us to handle. Acute low back pain usually settles remarkably well. You see, this guy is dancing very well because low back pain occurs in nearly 85 to 86% of patients at some point in their life, and majority of episodes of low back pain are self-limiting. That is why he is enjoying himself with a cone ice cream and dancing to glory. Acute low back pain, don't get worried. What are the risk factors? I'm sorry for this woman trying to do exercise. It can be associated with obesity, smoking, very physically strenuous work, mechanical labor, sedentary job. All of us, our doctors are sedentary only. We keep sitting only in the chair during consultation. What I do is for every patient, I go outside the consultation room, but definitely return inside with the patient. So I see off the patient and I also welcome the patient so that I don't continue to sit in the chair for a very long period of time. Now with COVID, I'm glued to this chair doing webinars. Psychological disturbances like depression can cause low back pain and jobs dissatisfaction at the work area. He may not be happy with this job. You may get a little depressed and he'll keep on saying, I got low back pain, low back pain. Just get a psychological assessment run of him, get into the ergonomics of his work environment, and probably if you change the profile of his job, he may be a little better. So non-specific low back pain, like the Buddha, you can sleep in peace for a day or two. You will definitely become fine. Just simple analgesics, hot packs, things will be all right. Nothing to get worried. Now there are important red flags in low back pain. This you should never forget. Red flag means danger signal. Systemic symptoms like fever, loss of weight, loss of appetite. Any person on immunosuppressive drugs, he can land up with discitis, epidural abscess. History of malignancy, breast, prostate, lung, thyroid and kidney. They can cause secondary metastasis. I have seen patients with secondary metastasis. Then I told you multiple myeloma. When there is a history of significant trauma, you will have to think of fracture. Nocturnal low back pain. Think of inflammation, ankylosing spondylitis. Think of malignancy, primary or secondary. Think of infection. And when the low back pain is not even responsive to opioids, then it is a red flag. These people have to be investigated very well. Now, what are the other red flags in low back pain? See, I just got a back pain, and it's just limited to my low back. But when this low back pain becomes a predominant leg pain, that means he's got neurological symptoms. It can be sensory or motor. That means there's a disc pathology, can be lumbar canal stenosis also. It's a red flag. What are the visceral symptoms? Symptoms of suggestive of pancreatitis, burning, micturition, fever, etc. Radiculopathy, sciatica. Neurogenic claudication. You walk for a long distance, you develop sensory deficit, motor deficit, becoming better when you straighten the spine. And these the other one too are very, very important. When there is low back pain associated with disturbances with bladder and bowel function, with saddle area anesthesia, please think of Cauda-Icona syndrome. Every person with low back pain, you must ask for a history of disturbances in the bladder and the bowel function. And I told you lower limb motor or sensory symptoms without neurological deficit. So important red flags, as I told you earlier, are systemic symptoms, loss of weight, immunosuppressive drugs, history of malignancy and causing secondaries, multiple myeloma, significant trauma, nocturnal low back pain, and low back pain unresponsive to even opioids, presence of neurological symptoms, visceral symptoms, sciatica, neurogenic claudication, disturbances in bowel and bladder. That's very, very important. Now see, this is a patient with multiple myeloma. You can see the multiple punched out lesions in the skull, and this person, they did a bone marrow, and you see there is a total replacement of the bone marrow element by plasma cells. So kindly think of multiple myeloma when any person presents with excruciating low back pain, loss of weight and loss of appetite, significant anemia, ESR more than 100, with or without azotemia. Kindly think of multiple myeloma because it's a treatable condition. The earlier you diagnose it, the better. And to be very frank, in my initial days of my practice, I also missed patients with multiple myeloma. Now I don't, because I'm very, very aware and careful about not missing the diagnosis. So how will you make a diagnosis of low back pain? History is very important. We are in an era where taking history has become mystery. Clinical examination has also become history. Why lab investigations? Is it to make a purse full? Low back pain, just go and get a MRI done and come. That's not. Take a good history, go a good general examination, examination of the spine, the gait of the person, the neurological examination, the straight leg raising test, and other systems. I tell you one thing, a good physician is one who follows the Hutchinson's clinical methods of diagnosis. History, clinical examination, provisional diagnosis, relevant investigations, and then specific diagnosis. It's now used just taking a paper and writing, go and do MRA, go and do CT, go and do DEXA scan. I think it's absolute crazy. So laboratory investigations, very important is hemogram, low hemoglobin, think of myeloma. Elevated ESR can be infection or malignancy. Altered renal function, think of myeloma or renal disease. Liver function, elevated alkaline phosphatase, think of Paget's. Vitamin D3 level low insufficiency is quite common in India. It can also cause low back pain. If CRP is elevated, it means it is inflammatory.